Position manual stability, also known as POMS. When is POMS used? It's used to treat non-structural dysfunctions. So remember your list of non-structural dysfunctions: alignment, upper motor neuron, lower motor neuron disease or injury, inflammation, etc., etc. It would not be used for psychological dysfunctions. So again, we're going to use it appropriately. It is also used to re-educate for stability after a release technique. So with the foot and ankle, it is very important with regard to balance that we provide as much articulation of the foot on the floor appropriately. And therefore, so if we mobilize, let's say, a big toe to articulate with the floor more appropriately, we're going to want to re-educate that big toe to stay on the ground. So we would be using position of manual stability to do that. So anytime you want to re-educate stability, and remember, stability is no movement, it is position, you would use POMS. It is also used to manage pain. So if somebody has pain or inflammation in a particular area, they can place their hand in the position and use the POMS technique to help to decrease pain, as well as, remember, stability equals mobility. So they can also stabilize to increase movement. And this happens a lot with a fixed bunion. If you provide the POMS technique to a bunion that does not move, it will be able to move when you've applied the position of manual stability. So I did this with a patient who needed to get her foot into a brace for her bunion. She would tape into the position of manual stability and be able then to move her big toe into the appropriate position for the brace. We had a patient in class, or an individual in class once, who slammed her thumb into a door and she wasn't able to move it. And when she applied POMS to not the direct injury, but the base of support of it, so in this case, her first metacarpal, she was able to move her thumb. So again, that can be used for that in pain management and also mobility. It can be used to determine the direction of taping. So now a lot of people are doing kinesiotaping. And what I do with kinesiotaping is, if I'm taping, I'll be taping for stability. I will test the direction that the person is most stable using position of manual stability, and then tape in that direction for support for the patient. It can also be used by the patient as a self-treatment. So if the patient is experiencing pain, they can provide the POMS technique at the area of pain to help decrease it, and or also apply a piece of tape in that direction to help maintain a little bit of pain relief. So here are some of the characteristics of POMS. As I mentioned earlier, it increases range of motion because you need to have stability in order to have mobility. It improves, as I mentioned, stability, balance, decreases pain and crepitus for a damaged joint or area. So if I have a patient where I know they have a painful arthritic point or location in their foot or elsewhere in the body, I will apply POMS to that area, especially if it's very sensitive. Sometimes that's the first thing I start with, because movement in and of itself is too painful at this point. So I want to elicit stabilization in that area, because again, stabilization increases mobility, as well as, think about it, what do surgeons do to decrease pain in an area? They either replace the joint or they fuse it. And what is fusion? It's a stabilization of the area. So we're just doing this naturally. Another thing that I want to mention, and it goes along with number 3, which is you use it to treat non-structural dysfunctions, but bear in mind that treating these things will not last unless you address the underlying reason for that non-structural dysfunction. So think about it. If somebody has chronic inflammation, it will probably help for them to take an anti-inflammatory med or get an injection to get rid of that inflammation, because if let's say you've reinstated stability, and then the patient goes, walks 10 miles and gets that inflammatory process going again, all of your work will be for naught. So we need to address the underlying condition in order to maintain our gains, and be aware that we may not be able to do it permanently, that the patient will have to learn how to do this on their own as part of maybe their home exercise program. Another characteristic is that the force is in a diagonal direction on a specific area. Now, that area might be big and large like a calf, or it might be really small like a baby toe, okay, the fifth toe. So we want to make our hand placement appropriate for the size of the area that we are covering. So for a large area, I might use my entire palm, or sometimes I'll even use my forearm. And for a small area, I'm just going to use my finger. So keep that in mind. The force can be on any side of the structure. So it could be on the dorsum, it could be on the plantar surface, it could be on the medial or lateral surface. So what is this sounding like? It's actually sounding like the stabilizing hand for the arms technique. And guess what? That is exactly what it is. It is the stabilizing component of the arms release technique. So there is a relationship between POMS and arms. It is used, POMS is used to help release dysfunctional tissue during the arms technique and decrease the sensation of pain during that mobilization of the structural dysfunction. So really, arms without the mobilizing hand is POMS. But again, we are choosing our appropriate treatment. When are we going to use arms? We're going to use arms to release a structural dysfunction. If there is not a structural dysfunction, do not use arms or any other release technique. You're wasting your time. But if there is a non-structural dysfunction or something that needs to be stabilized, something that needs to have pain decreased, a decrease in movement due to pain or inflammation, a non-structural dysfunction, then we would also use POMS. It can also be used for upper and lower motor neuron disease or dysfunction. Because again, we can't change what's going on or what has happened to the brain or the spinal cord. Only time and healing will do that. But what we can do is elicit stabilization to that traumatized area or the base of support of that traumatized area using position of manual stability or POMS. You might ask, what is stability and how do we determine it? And it is a bit elusive and hasn't really been taught to us in most of our previous trainings. The first thing to remember, you must remember, stability does not equal motion. Therefore, as your force is applied, there should not be movement in the structure that you are trying to elicit stability. And I'll say it again, stability does not equal movement. There should be no movement in the area that you are trying to stabilize. And along the lines with that, to note if you are in the appropriate direction for the position of manual stability, you can, as a therapist, continue to increase your resistive force and the patient will remain stable, but only if you're doing it appropriately. And that's where knowing how much force to apply, that's why I use the analogy of the force is like pushing a penny across a table. That's how little force you are going to begin with. If you apply with too much force, you're going to blow through the stabilizing muscles and the patient will then move. So if you are not eliciting this response in your patient, the second reason would be that you are moving too hard, too fast. Remember, finesse, not force. Also remember that the primary reason that most people do not elicit the position of manual stability is because of their setup position. Remember, the forearm and ideally the pelvis must be in the direction of the diagonal force. Another characteristic is that it will make a restriction, a structural dysfunction, less painful if your goal is to release that structural dysfunction. Again, this is part of the arms release technique, and I understand this could be a little bit confusing. Reread the relationship between arms and POMS if this is confusing you. It will make the patient feel more stable or comfortable. So again, we can use our communication skills with our patient and ask them, what direction makes you feel most comfortable, most secure? And we can also use the visualization or sight by looking at that area. And typically when you are in the appropriate direction, there will be less movement of the clothing, if you're on top of clothing or on top or on the skin when you are in the appropriate position of manual stability. So again, you can use your eyes to observe and see which direction creates less movement of the clothing or the skin, and that is likely your position of manual stability. Finally, again, I can't stress this enough. Stability does not equal movement. So there will be no movement of the joints that you are trying to stabilize, nor the joints above or below that area. So now we know about the POMS technique, when it's used, and some characteristics of it. But now let's learn how to do it. It's very important, in fact, vital, that the therapist orient themselves in such a way where their forearm and ideally their pelvis are in the direction of the push or the pull. This is a PNF principle, and if you are not feeling a release during the arms technique when you're doing stabilization, or if you're not feeling the position of manual stability when you're treating a non-structural dysfunction, this is probably what you are doing wrong. You will need to check in with your body position and make sure that at least the forearm is in the direction of the push or pull, and ideally your pelvis as well. Sometimes that's impossible, especially when we're working with the toe or different areas of the body, but the forearm is integral. So make sure that at least the forearm is in the direction of the push or pull. So step one. Again, if we're doing a large body part, we're going to use our whole hands, or if we're doing a small body part, we'll just use our finger. What you're going to do is dent the skin, okay, by applying an inward pressure to the body, okay? At that point, you are going to slowly, with the amount of force that it takes to push a penny across a table, slowly and gradually move in a diagonal direction, either toward or away from the patient. So you're going to dent the skin, move upward, assess the stabilization. Does the patient feel like they become more stable? If you're using this for the arms release technique, does that restriction become lessened? Is there less movement of the clothing or the skin in this direction? And you will feel kind of a resistance pushing back at you when you are in the appropriate direction for position of manual stability. An important characteristic of this technique is finesse, not force. Finesse, not force. It's kind of a dance. As you apply your force, your patient is then able to resist you. As you increase that force, the patient is still able to resist you up to a point. Here are various examples of the position of manual stability, or POMS, the hand placement that's being utilized. And you'll note in the pictures I am doing this on myself, so the technique really actually could be better. The first one is an example of what you would do on a broad surface where you could use your whole hand. The surface area is large, so I can utilize the whole palm of my hand. I will dent into the skin and gently, again with the force of pushing a penny across a table, elicit a force away on a diagonal or toward me on a diagonal. Now, I am violating a very important principle here, is that my forearm actually should be along that diagonal on the floor. However, I am kneeling in this picture, so I'm just physically not able to do that. In the next example, this is the POMS technique on a hallux, and this is a very common area where I would use POMS because it's so important for the big toe to be onto the floor, and many people are not weight bearing through their big toe, number one, and number two, almost every compensation that occurs in a foot and a knee is to get that big toe onto the floor. So almost all of your patients are going to require this technique using POMS, this re-education technique. And in this example, I'm on the medial border of the hallux, and my finger is articulating with the surface because it's a small area, and I am in the diagonal. I am applying a force underneath the toe. Now, the reason why I went underneath the toe is because I want that toe articulating with the floor. So I want to facilitate action on that side of the body. So I would not choose the top of the toe in this particular re-education. I would choose the underside. And I would dent the skin up and gradually move my force away or toward my body as I'm going up. I could also take my other hands and put it on the lateral surface of the hallux right there, and again apply my diagonal force away or toward. I would choose the one that elicits the stronger reaction from the patient. And as I'm holding the position in POMS, I could have the patient moving other parts of their body to maintain stability through the foot in this first example, or the hallux in this example. And a very functional movement that I'll do with patients is just the weight-bearing phase of gait, the stance phase of gait, going backward, taking a step backward and forward, and keeping the foot that I am stabilizing onto the floor through that step back and forward. So what happens if you can't feel the direction of the position of manual stability? Well, the first one is to make sure that the forearm and, if possible, the body is in the direction of your force. Again, as I pointed out in those pictures, that is the most common mistake that someone will make when performing the position of manual stability. So if you're doing it and you're not feeling that core muscle engagement or that stability within the patient, and you are seeing movement, make sure that that forearm is, at least the forearm is in the direction of the diagonal. The second thing you could do, just like when we're doing palpation, is you could ask the patient what direction makes them feel more comfortable. Or if you're doing this in conjunction with the arms release technique, you can ask them which position makes that tissue feel less tender or decrease pain. When you are doing this technique, 80 to 95% of your force is up or down. Very little of your force is involved in denting the skin. So bear in mind that you're not really pushing into the skin. You're just trying to elicit a kind of an area to move upon. Okay. You could also close your eyes because you are better able to feel if you knock out your visual sense. You could use your visual sense to look to see where the skin is moving less or the clothing is less wrinkled when you are eliciting your pulling or pushing. You want to generate your force via your body weight, and this goes for any manual therapy technique, including palpation. Always use your body weight. And the push comes from the shoulder girdle and the weight shift rather than from the hand. Make sure you're not holding your breath, and bear in mind that as you increase your force, you are going to be working a lot harder than your patient. And lastly, note that there might be more than one direction that elicits stability in your patient. And the one that you're going to choose is the one that makes the most stable, if that's your goal, And if your goal is to help release the tissue during the arms release technique, then it's going to be the direction that releases the tissue most. So what if you still can't feel POMS? Well, you just change your hand placement. So I've given you 3 examples here. Here's the anterior of somebody's knee that has just had a knee replacement. So that would not be a good position. So let's say we had someone with a knee replacement recent that we wanted to do POMS on, which would be completely appropriate since there's a lot of swelling, a lot of trauma, inflammation, and a lot of core muscle shutdown and decreased range of motion. So while this person is doing their CPM, placing their hand or your hand in the position of manual stability could significantly decrease the sensation of pain during that activity. So we could choose the posterior part of that patient's leg. This is the back of a patient's knee. And again, we would sink our hand right into the posterior area, and we would generate a force either up and in or down and out. Or we could take our other hand and generate our force, dent the skin, and go up and in and down and out. So there are 4 options on the posterior portion of this patient's knee that we could use to elicit POMS. Or if, let's say, the patient's going on the CPM and we're not going to be there, we could do some kinesiotape. So here's some kinesiotape in diagonal direction. So we're on the lateral border of the knee. We dent the skin. We see if the direction that stabilizes the patient, the position of manual stability or POMS, is up and out or down and in. Let's say it's up and out. Well, then we would secure our kinesiotape on the down and in portion and pull the tape up and out. Okay, let's say there's another direction or we want to create more stability in that knee. Well, we could then try this direction, this diagonal. So we'll start here and we'll generate our force up and out or down and in. So let's say down and in, this direction was the direction that elicited stability and decreased pain. We would take our kinesiotape here and pull it in this direction right here. And the same would be true if we wanted to choose the medial side, etc. So when you think about it, you have 4 options on any particular side of a patient's structure. So you have 16 different potential directions of positional of manual stability. 4 on each part, 4 sides of a structure. That equals 16 potential positions of manual stability. You are bound to find one in your patient. Before we move on to lab, let's review the position of manual stability technique and principles. First, begin with the weight of your hands on a patient. Do not really push in. You dent the skin. Remember, finesse, not force. You're not going for the marrow here. Maintain normal breathing within your own system. Okay, do not hold your breath. Your command to your patient is hold, don't let me move you. I will rarely, if ever, say push or pull into my hand to my patient because pushing and pulling gives the assumption that there is movement, and I don't want my patient to overpower me. I want to be in control of the amount of force that they are going to generate into my hand. So if I build slowly, again, our core muscles should kick in first before our movers, and that's the idea. So we want them to hold because stability does not equal motion. Do not overpower your patient. You'll do this if you create movement. Stability, again, does not equal movement. You will gradually build your force and your patient will be able to resist you. That's how you know that you're in that right direction, because as you keep generating your force to a point, they will still be able to resist you without moving. And that is truly where you get your training of position of manual stability. And you'll want to hold that position for about 15 to 30 seconds. I didn't mention that earlier, but typically that will be all that you need to awaken those stability muscles that you are facilitating during this technique. You can hold for longer and you can have the patient do, like I said, some functional activities as you are holding. That's a great way to train your patient for stability as well as function. And now we'll be moving into lab. The position for this lab will be the same as the position was for the arms release technique lab. You will either be kneeling on a pillow with your foot in front and working with your hands on the front foot, or you will have your foot up on a step stool and you will be leaning over and working in that position. We are looking at position of manual stability, and again, this is used for areas that are known to have inflammation or some other kinds of instability. Remember, stability does not equal movement. So if you've done your single leg stance test and you see quivering or movement in a particular area, that is where you're going to stabilize. Let's say that we've had a sprained ankle on the lateral side. You'll take your hand with your fingers pointed in a diagonal, dent the skin, and gradually move away toward the toes or up and in toward your body. This is a common area for inflammation, as ankle sprains are very common among individuals, male or female, of any age. You will choose the direction that elicits the greatest feeling of security, stability, and most importantly, no movement. If you see movement, then you are not being stable. If that hand did not work, we're now trying the other hand, dent the skin and move toward the calcaneus or the heel, or move up and away diagonally across the front of the tibia and fibula toward the upper part of the body. Again, we're going to feel for a lack of motion, a feeling of stabilization. If you're observing, you want to look for no wrinkles. I can then apply a piece of kinesio tape in that direction across the lateral malleoli to assist with the feeling of stabilization. Now I'm going toward the bunion on my pinky toe, and again I'll use my finger since this is a small region. I will skin lock and move away and lateral to the pinky. Again, it looks like it is a good position because there are not many wrinkling of the skin and I do not see movement of the foot or the toe. Now I will try the other direction. And either of those directions looks completely fine because I am not seeing any wrinkles to that area. So I am go with the direction that elicits a greater feeling of stability within my system. So you might need to ask your patient which direction feels better for them. Now I will attempt using my other hand to go into the other diagonal, and I will skin lock and pull toward my body and look and feel. I'm looking for wrinkles and I'm feeling for stabilization. Note that the finger is in line with my forearm as I'm doing this. And now I will go ahead and decide to maybe put a piece of tape in that position. What I'm showing you right now is that pulling in that direction with that hand would not be good with my right hand because my forearm was not in the correct diagonal. Next, we'll be looking at the first metatarsal and the hallux. So we test the position of the hallux onto the floor and feel for the position that comes up because that means that there's no stability. I find that it is on the inside of my hallux, so I will now take my finger, skin lock, and again notice my forearm, dent the skin, and move away from the body, and see how that feels, and then move in the opposite direction. I now try the other diagonal with the other hand, skin lock, and I am going to pull away And then I will try denting the skin and pushing toward. If pulling away works, I'll affix a piece of tape in that direction, or do that as my patient performs functional motion that we showed you in a previous slide, how I'll often use this technique with patients whose big toe is coming off the ground, which is integral for balance, having that big toe on the ground, and I might have them doing stepping forward or backward, or in this case, foot clocks in a position of kneeling. Now I'm attempting the lateral side, and I can apply a inward force, and now I'm resisting upward to keep the bottom of the hallux onto the floor. And again, this would be a good position for me to use when I'm having my patient do functional activity, such as foot clocks, stepping forward, stepping backward, etc. I am performing a prolonged hold in this area, and again, I typically hold for 15 to 30 seconds. I could also choose to go a little bit more proximal on the underside of the hallux, depending on where the instability lie. And again, I'm applying a diagonal force into the skin and away. Now I will retest, and I see an increase in stabilization of that medial hallux, whereas prior to that experience, I was able to lift that part of the hallux off of the floor. And laterally, I am still stable as well. So my position of manual stability elicited an increase in the weight bearing of my hallux. Again, a very important place to weight bear when you are dealing with patients who lack balance.